Her talk is Advancing Personalized Medicine with Cardiovascular Genomics. Please.
Thank you very much. Thank you for the kind introduction, and thank you so much for inviting me to speak at this wonderful event, and congratulations on the 40th anniversary of SCL. I have to say I've just been extremely impressed with everything here in this beautiful city and country. The hospitality has been just phenomenal, and it's really a true pleasure to be here, so thank you so much. So today I'm going to talk to you about cardiovascular genomics. And my overview is basically 4 major points. I'm going to talk the most about hereditary cardiovascular disease and individualized medicine, a little bit about cardiovascular pharmacogenomics, a little bit about polygenic risk scores, and a little bit about future directions for cardiovascular genomic medicine. So when we're talking about inherited cardiovascular disorders, we often refer to them as monogenic cardiovascular disorders. And there's 4 major categories: cardiomyopathies, arrhythmias, aortopathies, and dyslipidemias. And within these categories, there's many different subtypes of inherited disease. And for almost all of these, we do understand a lot of the underlying genetic cause, so we can test for them. And although we call them monogenic, most of them exhibit quite a bit of genetic heterogeneity, where there's more than one gene responsible for a single disorder. So we need to have the capability to test for multiple genes. They also have quite a bit of phenotypic overlap. So disorders that have distinct genetic causes might present the same way phenotypically and can be difficult to diagnose based on clinical presentation alone. So when a particular condition is suspected, it's very important for us to be able to test for multiple genes. And the utility for doing this is obviously diagnosis, but there's also a lot of applications in cardiovascular genetic medicine where we can provide more specific management to the patient based on the genes involved. And we can also provide predictive testing for family members and hopefully earlier intervention, as well as family planning. So the major platform that we use for genetic testing is next-generation sequencing. And I've been involved in this field for a while, and it's really been wonderful over the past 15 or so years that we now have this technology available to us so that we can use NGS to test for multiple genes. For this group of disorders, we don't do exome sequencing or genome sequencing. We want to provide more targeted sequencing of specific genes that are relevant to the disorders, and then provide comprehensive analysis of each gene. So we can look at single nucleotide variants and copy number variants, and we can also provide a comprehensive analysis of genes that have pseudogenes associated with them. And so our gene panel design, again, we just want to look at relevant genes so that we can provide a meaningful interpretation instead of having genes of uncertain significance, which create a messier clinical report. And then it's really important for laboratories that provide this type of testing to have disease and gene-specific expertise so that when the results come off the sequencer, the individuals interpreting the results understand the implications of the results and can correlate those to the patient phenotype. So in my laboratory, we have multiple genetic counselors, we have cardiovascular pathologists, we have genetics lab directors like myself, and we also have clinicians, specifically cardiologists, that can help us to understand the overall picture of the patient phenotype and genotype. So I'd like to dive into aortopathies as an example. Aortopathies are a really nice group of disorders that that demonstrate some of these different principles that I'm talking about today. They have genetic heterogeneity. They have a lot of phenotypic overlap. They have many examples of gene-based management strategies, and they also have examples of genetic variant-based prediction. So aortopathies are characterized by aortic aneurysms and dissections. They can be non-syndromic or syndromic. Non-syndromic is called heritable thoracic aneurysm and dissection, or HTAD. And then in the syndromic category, there's multiple different syndromic aortopathies, but the three most common are Marfan syndrome, Loeys-Dietz syndrome, and vascular Ehlers-Danlos. And these three conditions in particular can present with overlapping features. As I mentioned earlier, they may present clinically in one way that they become misdiagnosed. So there's been numerous examples of, for example, patients who meet the clinical criteria for Marfan syndrome actually having Loeys-Dietz syndrome, and patients with vascular Ehlers-Danlos syndrome actually having Loeys-Dietz syndrome, and vice versa. And so a lot of these, they not only have the aortic aneurysm and dissection, but they also have skeletal features, skin-based features that overlap with each other. And then again, we have this genetic heterogeneity, so there's many different genes involved in these conditions. On the right, you can see this graph, or this figure with a lot of different genes involved in these conditions, genes related to vascular smooth muscle cell function, TGF-beta signaling, and extracellular matrix formation. So genetic testing, again, can help clarify the diagnosis. It can also predict the phenotype and prognosis, and it may help dictate the management of the patient in terms of aortic imaging and other vascular imaging that might need to take place, aortic surgical thresholds, and surveillance for other complications. And this picture here was published a couple of years ago, but it highlights, the way the field is advancing, and there's a lot of new recommendations that are being published for genetic testing for these conditions and management of these conditions. So in the top box, you can see that in patients who have an aortic dissection, who are younger, with no history of smoking or hypertension, and who may have a family history of aortic disease, they should really be considered for genetic testing. The triangle shows the main genes involved, but in the previous slide I showed you a lot of other genes, and more physicians are leaning towards larger panels of genes because they want to be more comprehensive. And then in the left box, you can see when to operate. So prophylactic aortic root surgery is often performed in these patients, and it's actually dependent on the gene involved. So the aortic root diameter is measured, and it's measured over time. And when it gets to be a certain threshold, for example, greater than or equal to 5 centimeters for FBN1, then the patient will undergo this prophylactic surgery. And this table here shows a little bit more information related to what I just showed you in terms of how frequently the aorta should be imaged, and then other vascular imaging. So what we found is that, for example, with FBN1, the aneurysm and dissection is mainly isolated to the thoracic aorta, but other conditions like Loeys-Dietz can have other aortic involvement, for example, carotid or abdominal. So more extensive imaging, head to pelvis, is recommended for different genes. And then there's other cardiovascular findings to be on the lookout for, depending on the gene involved. And as we're learning more, there's more studies are done, more publications. This study came out last year with Diana Milowitz's group looking at heritable thoracic aortic disease genes and found all sorts of interesting associations with, for example, type B versus type A dissection, age of dissection, and other aortic events associated with specific genes and specific variants. And so a good example of this variant-specific association is with FBN1, the gene that underlies Marfan syndrome. And fibrillin-1 is a large gene. It's 64 exons, and it encodes for fibrillin-1, which are these monomers that assemble into these microfibrils. There's two major types of variants in fibrillin-1. There's the dominant negative variant, which is usually a missense variant, and it creates some sort of structural or functional alteration in the protein. And then the other type of variant is known as a haploinsufficient variant. This is usually a nonsense variant that leads to protein truncation, so then you'll have reduced amounts of fibrillin microfibrils. And for a long time, it was thought that these haploinsufficient variants actually led to less severe disease, and patients were often counseled as to maybe not worry so much about having a cardiovascular event because they have a haploinsufficient variant. So we were actually surprised because we took a look at our patient database, and we looked at the correlation between genotype and phenotype, and we were actually surprised in that we studied these patients with likely pathogenic and pathogenic variants, and we were surprised that the patients with the haploinsufficient variants actually more often met Ghent criteria for Marfan syndrome, which is the clinical criteria, and they also had more severe cardiovascular complications. And this was demonstrated by numerous other studies. It was corroborated. And this graph here shows just the correlation between aortic root diameter and then the haploinsufficient versus dominant negative variants. So again, this is just a nice highlight of why genetic testing is important for these conditions and how specific variants can give you a better idea of prognosis. I'm going to transition and talk about familial hypercholesterolemia, which is a very common genetic disorder. It's probably the most common genetic disorder worldwide, about 1 in 200 and higher in some populations. It's an autosomal codominant disorder resulting in severe hypercholesterolemia, specifically LDL cholesterol. It can be in the heterozygous or homozygous state, and these different features can be present, like skin and tendinous xanthomas, arcus corneae, and of course, cardiovascular disease early in life. There's a lot of genes involved in this phenotype, as you can see here. The 3 most common are highlighted in yellow, and particularly LDLR, the encoding for the LDL receptor, is the most common cause. But studies have shown, actually numerous studies have shown that in individuals who have the same high levels of LDL, if they have a genetic cause, they're going to have a much higher incidence of coronary artery disease. So again, another reason of why genetic testing is important, even though you can say, okay, this person has very high LDL, we could probably test their family members and they probably may or may not have high LDL, but the relevance is that you're pinpointing a genetic cause, and then as we learn more about the different genes involved, there's different therapies that can be considered. And there's other genotype-phenotype correlations with these genes, depending on the variant present, depending on whether it's heterozygous or homozygous, and stenosis is usually present. ApoB, the ApoB gene, generally has a milder phenotype. And then we also have seen many cases where these oligogenic effects. so that there's additive effects of the genes. So if multiple genes have variants present, we can see a more severe phenotype. So again, this genetic gene panel testing is very helpful. There's different treatment strategies depending on whether it's heterozygous or homozygous FH, and I won't go into detail on this. And then there's a lot of emerging therapies. You're probably familiar with that we do have injectable PCSK9 inhibitors available right now. Well, they're working on an oral form. There's cholesterol ester transferase protein inhibitors in development, CRISPR gene editing, vaccines. So a lot of things on the horizon. So another type of heritable genetic disorder are the arrhythmia syndromes. And these are due to dysfunctions of cardiac ion channel subunits, or the proteins that regulate them. These are actually an important cause of sudden death. And we do a lot of postmortem analyses in our laboratory for mainly for arrhythmias and cardiomyopathies. And so about 60% of sudden death is due to a cardiovascular cause. And most of those are cardiomyopathies or arrhythmias. But if you have an arrhythmia, it's not a structural cardiovascular, there's not a structural cardiovascular component to it. So when sudden death happens, and it's potentially in a younger individual who's maybe swimming, that's probably the most common thing that we see, and there's no explainable physiological reason, it's often due to an arrhythmia. There's many different types of arrhythmia syndrome. The most common is long QT syndrome, and you can see the EKG here for long QT syndrome. There's several differentiating features of hereditary arrhythmias. So the highest risk population impacted, male versus female, age, different EKG patterns, and then also typical event triggers. So for example, with long QT1 and CPVT, there's typically it's exercise that triggers it. Long QT2 is usually auditory stimulation, so an alarm going off in the middle of the night, a baby crying in the middle of the night. And then with long QT3 and Brugada syndrome, those are usually triggered by, unfortunately, sleep and rest, and then also fever. And this study looked at precision medicine in long QT syndrome. So again, just trying to hone in on genotype therapy correlations. They looked at the three most common types of long QT. There's 15 subtypes of long QT. They looked at types 1 through 3, and they found that the treatment was dependent on the gene involved, also the baseline QTC interval, so the EKG measurement, any events, and response to beta blockers if the patient was already on a beta blocker. And despite previous conventional wisdom, they found that most patients didn't require ICD therapy. And then they also found some correlations with the gene and variants for the best type of treatment. So this is something that's a little bit in its early stages, but as it's being studied more and more, we're going to be able to provide more precision medicine approaches for arrhythmias. Here's just some other examples of precision medicine in cardiology, so including long QT syndrome, CPVT, hypertrophic cardiomyopathy, FH, which I already talked about. And then we have pharmacogenetic applications, which I'm sure many of you are familiar with, for example, with warfarin, statins, and clopidogrel. So I want to talk about clopidogrel. Clopidogrel, or Plavix, is an important treatment used in interventional cardiology. So patients who undergo percutaneous coronary intervention receive standard of care therapy. It's usually aspirin plus a antiplatelet inhibitor, most commonly clopidogrel or Plavix. And this therapy is, of course, very important to try to prevent adverse ischemic related events. But it's inevitably associated with an increased risk of bleeding, which makes sense. And it can also be associated with inefficacy. So fine-tuning this treatment is sometimes quite a process because there needs to be an optimal balance between ischemic and bleeding risk. And although Plavix or clopidogrel is most commonly prescribed, it does have a suboptimal platelet activation in about 30% of patients. And this is in part due to genetics. So clopidogrel itself is given as a prodrug. It's given in the inactive form, and then it's activated by the most prevalent enzyme that activates it is CYP2C19. And CYP2C19 is very polymorphic, so it has a lot of genetic variants in it, especially STAR2 and STAR3. And you're probably familiar with the fact that STAR2 and STAR3 are pretty common in the East Asian population. They're common in other populations as well across the world, but they're especially common in the East Asian population. So we published this study a few years ago, the Taylor PCI randomized clinical trial. This was an international 40-site study where we looked at 5,300 patients undergoing PCI, and they were randomized to 2 arms. One was standard of care, and the other one was a genotype-guided arm. So they were, at the time of PCI, they underwent genotyping, a rapid genotyping method, and then that dictated whether they were going to receive clopidogrel or ticagrelor, a different antiplatelet therapy. And then we followed up after 1 year to do the data analysis, and the primary endpoint was a composite of cardiovascular death, MI, stroke, stent thrombosis, and severe recurrent ischemia. Interestingly, despite what we thought was going to happen, we didn't find any statistical difference at this 12-month endpoint. However, we realized that we probably had too ambitious of a power, 85% power, to show a 50% reduction in the primary endpoint. And we also realized we probably were looking too far down the road. So when we did a post-hoc analysis at 3 months, we found that there was a statistically significant difference in hazard ratio with a nearly 80% reduction in adverse events in the genotype-guided arm. So this helped us to realize that this potential effect of this approach is probably more important early after PCI. A subsequent study or analysis of the data also showed that there is a 40% reduction in cumulative ischemic events per patient in the genotype-guided group. And so these studies have helped us, again, to understand that the importance of doing more prospective pharmacogenetics rather than retrospective, which is most commonly done today. And we're actually working on implementing a point-of-care genotyping test for patients undergoing PCI so that we can prescribe the appropriate medicine to them on the day that they receive their PCI. And now I want to talk about the polygenic nature of cardiovascular disease. So I've been talking a lot about heritable cardiovascular disease and monogenic cardiovascular disease, but we all know that cardiovascular disease has a large familial component that we don't understand very well, and the large majority of cardiovascular disease is polygenic and complex. So we can consider this to be due to the cumulative or additive effect of many common DNA variants, although, as Dr. Bauer pointed out, we can't really add the variants together. It's not that simple. There's other calculations that need to be done that we don't understand that well. But we can work towards developing polygenic risk scores. And it's actually been, these polygenic risk scores have been highly studied in hypertension, coronary artery disease, diabetes, and atrial fibrillation. So if you compare monogenic causes versus polygenic causes of having increased cardiovascular risk, the monogenic causes only contribute to about 0.4% of the population, whereas 8% of us have a common high polygenic disease risk. So it would be really wonderful if we could be able to try and predict this. And as I mentioned, the polygenic risk scores have been studied pretty heavily in CAD, but unfortunately there's been a lot of variable outcomes. And this is due to heterogeneity in the studies, the populations that were examined, the numbers of variants, how were the risk scores calculated. So they're very difficult to compare. And then also the diversity is an issue, as Dr. Bauer pointed out. So currently 90% of GWAS data is of European ancestry. So we do not really understand polygenic risk in non-Europeans. And you can see here in this picture, if you compare the polygenic, the prediction accuracy for coronary artery disease polygenic risk in Europeans compared to Americans, South Asians, East Asians, and Africans, quite a big difference. So we need to be able to have ethnicity-specific polygenic risk scores. And it's going to take a lot of studying of a large number of individuals for us to get there. Additionally, the predictive risk of polygenic risk scores for coronary artery disease have been shown to be quite similar to our traditional cardiometabolic risk factors. So it begs to question, is it really, what's the clinical utility of performing this type of test? These tests are expensive. Most often, they're genome-wide types of tests, so those are expensive. You also have your calculation algorithm, which is subject to regulatory scrutiny. So they're not the easiest tests to develop and get through regulation, and then also get reimbursed for. Also, there have been really limited outcome studies with these polygenic risk scores and unclear clinical utility. You know, what exactly is going to change if these polygenic risk scores are very similar to any other, you know, is the patient smoking, male, over a certain age, et cetera. You know, will it motivate lifestyle changes? Perhaps, but it's really unclear at this point. Are these polygenic risk scores accurate? There's so many different ways to calculate, so many different variants to look at, and then the other things that I just mentioned in the previous slide. Okay, finally, just a couple slides on future directions. So RNAs, and Dr. Bauer also talked a little bit about RNAs as novel biomarkers. This is really a very researchy area right now, but there's a lot that we can look at in terms of RNAs, in terms of different types of RNAs that are in the circulation, circular RNAs, microRNAs, as well as RNA modification enzymes and their impact on gene expression, which is transient, so it's not as easy to figure out as something like a DNA genomic variant, which is, you know, in every cell at all times. So it's a little bit trickier to figure out how the RNAs will be, can be used as biomarkers, but there's a lot of work being done on that. And also identifying different aspects of these RNAs for which therapies can be developed. And then Dr. Bauer really helped me out a lot with my talk because she talked about this as well, so I won't belabor any of this, but it's really, again, thinking about where do we need to go in terms of data integration, AI, multi-omics integration, looking at deep phenotyping, genomics, proteomics, metabolomics, transcriptomics, and combining all of that together to somehow make sense of understanding the mechanism and perhaps developing different types of therapies. And this slide basically points that out as well, so I won't go into this. But in summary, with heritable cardiovascular conditions, there's a lot of phenotypic and genotypic overlap, so we're really happy to have next generation sequencing as a technology where we can interrogate numerous genes to help with diagnosis, prognostic prediction, management, and familial testing. There's many different precision medicine applications, and I talked about pharmacogenetics with clopidogrel. Polygenic risk scores are great in theory, but we have a long ways to go to have a clinical application and then some future directions. So thank you very much for your attention.